I'd like to welcome Dr. Evangeline Jackson from the University of Newcastle. Floor is yours.
Awesome, thank you. Great. So firstly, I would like to thank the organisers for the opportunity to present here today. So diffuse midline gliomas are aggressive high-grade gliomas situated in the midline structures of the brain, primarily the brainstem and the pontine region of the brainstem, where they are termed DIPG. They have a median overall survival of less than 12 months and no long-term survivors. 80 to 90% of DMG cases harbour a lysine to methionine point mutation in histone 3, termed H3K27M, and this leads to a state of global hypomethylation, unravelling the chromatin, and this allows for transcription of genes responsible for proliferation and immune system avoidance. So currently, the only treatment available is radiotherapy, which is considered palliative as it only extends survival by around 3 months for those who do respond. And surgical resection is highly dangerous due to the diffuse nature and location of the tumour. Therefore, there is a desperate need for new effective therapies for the treatment of DMG. So ONC201 was first identified as a central nervous system active small molecule p53 independent inducer of trail-mediated apoptosis, yet whether that happens in DMG is unknown. And in phase 2 clinical trials, a 22-year-old patient harbouring H3K27M thalamic glioma experienced a near complete objective response when treated with 625 milligram once a week. So this encouraged the use of ONC201 to be used in DIPG and H3K27M mutant thalamic glioma, and in early phase clinical trials in the US, and that's got a preliminary reported efficacy of 21.7 months. And although this is a really encouraging 10-month extension on historical survival, patients are still succumbing to the disease less than 2 years after diagnosis. So how can we improve this survival benefit? So we set out to understand the molecular biology behind how ONC201 works, which will review new drug treatments to be used in combination treatment approaches. So somewhat mimicking the patient experience, testing 13 patient-derived DMG cell lines, we showed varied levels of sensitivity to ONC201 as measured by proliferation and annexin 5 positivity as a marker of cell death. So is there a genomic predictor of sensitivity? That's the question we sort of asked ourselves. So by employing the TrueSite Oncology 500 or TSO 500 next generation sequencing, we sought to identify recurring genomic alterations that might be indicative of a response. And unexpectedly, as I mentioned before, ONC201 was reported as a p53 independent inducer of apoptosis, yet we found that DMG cell lines harbouring TP53 mutations were in fact more resistant to ONC201. And we confirmed this using the ONC201 sensitive TP53 wild-type cell line HSJD007, where CRISPR-Cas9 mediated knockdown or knockout, mimicking that loss of TP53 function, indicated a TP53 dependent sensitivity to ONC201. And this is highlighted in this Western blot here following ONC201 treatment by this cleavage apart, which is a marker of cell death. And it's very clear in our non-targeting control is lessened in our knockdown and is not present at all in our knockout. So how does ONC201 work? Well, ONC201 was originally identified as a DRD2 antagonist by Bayesian machine learning, but also recently has been identified as a potent agonist of the mitochondrial protease CLPP. And CLPP regulates protein homeostasis in the mitochondria by using its molecular chaperone CLPX, which identifies misfolded proteins, tagging them to be proteolyzed by CLPP. However, ONC201 displaces CLPX, binding to CLPP, and this leads to the degradation of essential proteins in the mitochondria, such as in the TCA cycle and electron transport chain, and this leads to mitochondrial dysfunction. So at both the transcript and protein level, CLPP is overexpressed in diffuse high-grade gliomas, and this includes DMG. This highlights the therapeutic potential of CLPP agonism as ONC201 sensitivity increases with CLPP protein expression. And this is shown by a CRISPR-Cas9 mediated CLPP knockdown, which reduces sensitivity to ONC201 in our previously sensitive cell lines. So to determine mechanisms of resistance to ONC201, we performed quantitative proteomic profiling in our TP53 mutant ONC201 resistant cell line. So even though these cells are resistant to physiological concentrations of ONC201, mitochondrial dysfunction was still the top modulated network following ONC201 treatment. Indeed, significant CLPP-mediated proteolysis was shown of critical components of the electron transport chain and mitochondrial TCA cycle proteins such as SDHA and IDH3B. So when we take all of these significantly altered proteins and we put them through our Ingenuity pathway analysis software, the most predicted upregulated pathway is PI3 kinase AKT signaling, and this drives growth and proliferation. So ONC201 binds to CLPP, causing mitochondrial dysfunction, and this produces reactive oxygen species, which then activates PI3 kinase AKT signaling. And we confirm this by using the potent ROS scavenger N-acetylcysteine, which abrogates phosphorylation or activity of AKT, whereas hydrogen peroxide increased AKT phosphorylation. So inhibition of PI3 kinase AKT signaling may prevent AKT-mediated cell survival. So we began testing the blood-brain barrier permeable, clinically relevant PI3 kinase AKT inhibitor, paxalisib. So ONC201 in combination with paxalisib synergistically decreased cell proliferation and significantly reduced colony number in vitro in our ONC201 resistant cell lines. And this is because ONC201 drives AKT activity, which is silenced using paxalisib alone and in combination. Yet, does the combination work in vivo? Unfortunately, using paxalisib at its maximum tolerated dose, mice experienced toxicities, so we were only able to use it 3 times a week and showed an additive extension of survival when compared with ONC201. So we performed extensive dose optimization in mouse models and found that using half maximum tolerated dosing twice a day, we were able to combine with ONC201 at phase 1 dosing, showing a synergistic extension of survival. Again, as seen in vitro, this is because ONC201 drives PI3 kinase AKT signaling, which was reduced by the combination with paxalisib. So these data led to the compassionate access for a 16-year-old patient who had failed other therapies and was at advanced stages of the disease. She began the combination soon after completing re-irradiation, showing rapid tumour regression that was not seen following frontline radiation and dramatic neurological improvements. Unfortunately, she passed away unexpectedly from pneumonia, yet autopsy showed no evidence of tumour growth or tumour-related fatality. This led to the first patient to receive the combination of ONC201 and paxalisib 2 months after diagnosis. And this patient harboured H3.1K27M, PIK3R1 and ACVR1 mutations and was TP53 wild type. And although she had some good initial response to radiotherapy, there was some tumour growth in the time following. However, 9 months after being on the combination, had marked tumour regression, an 80% decrease compared to diagnosis. And this patient is now at 36 months at stable disease and continuing to do well with minimal toxicities. So these data underpin our international clinical trial, PNOC022, testing radiation plus and minus ONC201 in combination with paxalisib for children and young adults diagnosed with DMG. I would like to thank the team who are part of this work, especially Matt Dunn and Ryan Duchatel, our wonderful collaborators, and the funding which has supported our research.